moderator ತಗೊಳ್ಳಿ ಅವರು ಸಹ ಶಾ ಇದ್ದಾರೆ. ಹಾ. Yes. Very good morning to everyone present here. We, the residents of organ transplant anesthesia and critical care, will be presenting anesthetic considerations for daycare procedures, also termed as non-operating room anesthesia or NORA in liver disease patients today. I, Dr. Manigandan, final year DM resident, will be taking you through the following topics. What is NORA or non-operating room anesthesia and scope of NORA? Unique challenges faced by anesthetists during this setting. Pre-anesthetic evaluation of patients coming for various daycare procedures. Specific concerns in CLD patients. My colleagues Dr. Sai Kishore will be taking you through various NORA procedures at ILBS. And my colleague Dr. Hina will be taking you through the monitoring, various anesthetic techniques, and the innovations that we have made to overcome certain challenges that we face during these sedation procedures. Coming to the non-operating room anesthesia or NORA, American Society of Anesthesiologists defines NORA as care provided by anesthesiology personnel for inpatients or outpatients undergoing certain diagnostic or therapeutic procedures performed at locations outside an operating room pavilion within the hospital. Normally, we anesthetists are associated with providing care during surgical procedures, but in NORA, we are more associated with medical personnel like the hepatologist, gastroenterologist, and interventional radiologist. Most of these procedures are done under daycare admission, and it is one of the most burdened and high-risk areas because there is quick turnover of patients, and every day we get to see about 50 to 70 patients in daycare and minimum 10 sedation in interventional radiology suites. So it is one of the most high-risk areas because complex cases from pediatric to geriatric come here for sedation. Next, coming to the scope of NORA and ILBS, anesthesia team is associated with sedation in the hepatology daycare for all the procedures like diagnostic and therapeutic procedures, in the CT suite for procedural sedation and CT-guided biopsy. Vascular procedures, we are associated with providing sedation for TIPS, TARE, TACE, and PTBDs. And in the MRI suite also, we are providing sedation for procedures. We are also associated with shifting the patients from ICU for procedural sedation like CT, MRI, and emergency tips, etc. Most important challenge we face is pediatric sedation in the hepatology daycare. Next, coming to the unique obstacles faced by anesthesia personnel in NORA, there are three specific concerns. One is patient-related challenges, other is the procedure-related challenges, and the environment-related challenges. I'll be focusing on patient-related challenges in my presentation. So this is our pre-anesthesia record or the pre-anesthetic evaluation chart we follow in the daycare. We'll focus on brief history of the current disease and underlying comorbid conditions, general examination of the patient, systemic examination, particularly pertaining to the liver, airway examination, relevant investigations required for a procedure, NPO status and consent, and pre-medication. The main thing is that we don't have detailed time to evaluate the patients in daycare because the turnover rate is very high. So within a span of 5 or 10 minutes, we have to assess the patient from top to bottom, and we have to decide whether we can proceed with sedation or not. Coming to brief history and focused examination, our main idea is to identify the red flags during history taking. That is, if the patient has got any active cardiac or pulmonary disease, neurological disease or seizures, history of obstructive sleep apnea or airway disease like reactive airway, and prior anesthesia reactions. Medications and allergy history, including the intake of current medications like beta blockers, food, drug or latex allergy, and alcohol or substance abuse history. CLD specific history includes status of variceal bleeding, as presence of ascites like TENS ascites and hepatic encephalopathy. In the examination part, we'll focus on vitals and weight of the patient. Weight is very important in pediatrics because drug dosing is based on weight of the patient. Cardiopulmonary auscultation to rule out any lung infections, level of consciousness, and a brief airway assessment. Next, moving on to the unique challenges we face in CLD population include altered pharmacokinetics and dynamics. There is a reduced hepatic clearance of drugs, which means that the duration of action of the drugs will be prolonged. Hypoalbuminemia in these patients causes increased free fraction of protein-bound drugs, and portosystemic shunting increases the bioavailability of IV and oral sedatives. So the clinical implication is that we start with lower doses of drugs, slowly titrate them, and we can expect a longer recovery in these patients. Next is the unique challenge of hepatic encephalopathy in these patients. We all know that benzodiazepines and opioids can precipitate or worsen HE. Sedatives may mask early signs of HE in this population. Constipation and electrolyte imbalances further worsen HE. So our clinical implication would be to prefer propofol, which is a short-acting drug and has got rapid redistribution and minimal He precipitation tendency. We avoid or minimize the use of benzodiazepines like midazolam. Next, moving to cardiovascular concerns, all these CLD patients will have a low systemic vascular resistance. Cirrhotic cardiomyopathy will be present in approximately 40 to 50% of the population, and they have poor chronotropic response to stress. That is, their heart rate, their tendency to increase heart rate will be blunted, and they might be on preoperative beta blockers also. So the sedation we give can cause marked hypotension in these patients and reduced hepatic and renal perfusion. The clinical implications will be to maintain adequate preload because the patients will be on NPO from overnight. So it is better to start IV fluids in these patients, avoid a deep sedation and early vasopressor support if needed. Moving on to the respiratory concerns, TENS ascites in these patients can cause a decrease in functional residual capacity. In patients with TENS ascites, we usually avoid sedation and go with local anesthesia spray. Hepatopulmonary syndrome can be present in these patients and it can further contribute to hypoxia and desaturation. Most of the patients with ascites will also be having hydrothorax or pleural effusion, and portopulmonary hypertension present in these patients can cause right ventricular strain during sedation and sedation procedures. Risks during sedation include hypoventilation, hypoxia, and a easier tendency for desaturation and going into apnea. The clinical implications would include use of capnography to monitor the carbon dioxide levels in these patients. All patients should be provided with supplemental oxygen. Keep airway cart ready, that is for intubation or insertion of supraglottic airways, and target a lower sedation depth. So this is a patient whom we usually advise to go get the procedure done under local anesthesia, as the patient has got pleural effusion and can desaturate very well during the sedation procedure. Next, moving on to coagulation and procedure-specific issues. Coagulopathy and thrombocytopenia are very common in these patients, and sedation-related airway interventions like insertion of a nasopharyngeal airway during desaturation episode or insertion of endotracheal tube may cause bleeding in these patients. We always consider a patient with recent upper GI bleed, that is emetemesis or melena, to be full stomach, and we ask our hepatology team to start the procedure under local anesthesia always. Next, moving on to minimum investigations we need for sedating patients in daycare admission. For UGI endoscopy, we usually ask for hemoglobin if the patient is anemic, and in elderly patients, we ask for an RBS and ECG. Patients coming for ERCP, ECG is mandatory for patients coming for ERCP procedures apart from routine blood picture. And for TIPS, it is a very high-risk procedure, and patients can land up in RV failure post-TIPS. So we would like to have an ECG and a baseline echo for TIPS patients. For ASA 1 or 2 patients, that is patients coming with simple symptoms of GERD, etc., we don't ask for routine investigations in those patients. And cardiopulmonary clearances on a case-to-case basis, depending on pre-existing comorbidities, are mandatory. Next, moving to complications of sedation, cardiovascular-related complications include hypotension during induction of anesthesia, hypertension as an exaggerated response to stress, cardiac arrhythmias, and rarely myocardial ischemia. Respiratory complications are the most common we encounter during our sedation practice, and it includes respiratory depression, airway obstruction due to tongue fall, and pulmonary aspiration if the patient is not having adequate NPO status or if the patient is a bleeder. Allergic reaction to anesthetic drugs are rare. Nausea and vomiting is most common in the post-recovery period in the PACU, and paradoxical reactions like agitation, excessive talkativeness is very common in pediatric patients post-sedation. Next, moving on to risk stratification of ASA grading or ASA grading of cirrhotic patients. This is being given by the American Society of Anesthesiologists. Cirrhotic patients are considered very high-risk patients, and they have chances for increased mortality and morbidity post any anesthetic procedures. So if the patients are well compensated and have no ascites or no encephalopathy and coming under child A, they are classified as ASA 2 or 3. That is, they have mild to moderate systemic disease without major functional limitation. For early decompensations, we usually label them as ASA 3, which is significant systemic disease with functional limitation. Decompensated cirrhosis, including refractory ascites, refractory HE or variceal bleeding, or child C patients are labeled under ASA 4. That means they have a severe systemic disease that is a constant threat to life. Acute and chronic liver patients who come for any emergency procedures with multi-organ dysfunction, etc., are termed as ASA5, that is, they have life-threatening condition with high perioperative mortality. Next, moving on to the most important aspect, that is the NPO guidelines. Many times we encounter this issue during endoscopy. Patients come with inadequate NPO and we have to defer the procedure. According to the National Audit Project 4 that was recently held in the United Kingdom, aspiration was the leading cause of mortality and morbidity during administration of anesthetics, and it is a very serious medico-legal issue. So we always strictly adhere to the NPO guidelines. Now we have moved from a tendency of keeping the patients NPO from midnight and allowing clear liquids up to 2 hours before the procedure. Clear liquids will include water, black coffee, and non-carbonated beverages. For breast milk and infant formulas, the breast milk, the NPO guidelines is 4 hours. And for pediatric infant formula, the minimum NPO required is 6 hours. For a light meal like a bread toast, it is 6 hours. And for fatty meals, it is more than 8 hours. Why is NPO even more important in CLD patients? CLD patients are considered as functionally full stomach, so strict NPO is mandatory. The pathophysiology being delayed gastric emptying in these patients, presence of ascites causes increased intra-abdominal pressure and there can be lax of the lower esophageal sphincter. Encephalopathy present in these patients can cause poor airway reflexes and they are more prone for aspiration. Hypoalbuminemia can cause gut edema. So the clinical consequences include a chance of higher aspiration risk and rapid desaturation during the procedure. Even adequate fasting may be insufficient, so residual food can be present in the CLD patients. In order to improve the safety of the patient, we have done a study in our institute, preoperative oral carbohydrate fluid loading in cirrhotic patients for endoscopy daycare procedures under anesthesia. This is an RCT and it is yet to be published. The main aim was to assess the influence of preoperative oral administration of carbohydrate fluid. That is, we administered 100 ml of Apifis in cirrhotic patients on gastric emptying, which was assessed by gastric ultrasound in these patients and periprocedural well-being. A study sample was 195 and it was a well-conducted RCT. In this, we can see the ultrasound image where the stomach is filled with content. We assessed the peri-procedure well-being of thirst and well-being of the patient, and we looked into parameters like thirst, hunger, mouth dryness, patient satisfaction, nausea, vomiting, and fatigue in the control group who had standard NPO practice, and in those patients who received the API drink 2 hours before the procedure and 3 hours before the procedure. The sense of patient well-being was more in those patients who received the preoperative glucose drink. Next, moving to airway assessment. In the daycare procedures, there is no time for detailed airway assessment, so we quickly assess the patient's airway at the bedside. Most common assessment we do is the Mallampati score, where we assess the size of the tongue in relation to the oral cavity. There are 4 classes from class 1 to class 4, with class 1 being an easy airway and class 4 being a difficult airway. We also look into multiple parameters like mouth opening of the patients. These patients will be drug abuse patients or tobacco chewers, so their mouth opening will be restricted. We also look for thyromental distance, neck movement like flexion extension because the elderly patients can have cervical spine issues. And ability to prognathe the jaw is another important factor. We take into account a combination of all these factors to label the patient as an easy airway or a difficult airway. And CLD patients are already a physiologically difficult airway because of the presence of ascites, hydrothorax, HPS, making them prone for desaturation. Anatomical abnormalities can compound the difficulty. Next, moving on to the last part, that is whether pre-medication in CLD, importance, pros and cons. The importance of pre-medication is that it will reduce the anxiety, prevent aspiration, stabilize the hemodynamics during the preoperative period, and in pediatrics, it will help to overcome the separation anxiety. Pros include an anxiolysis and a good aspiration prophylaxis. Cons include a risk of over-sedation, HE precipitation, and drug accumulation. Drugs we commonly prefer are a proton pump inhibitor or H2 blocker, metoclopramide, glycopyrrolate, especially we use this in long duration procedures like ERCP or EUS to decrease the secretions. Benzodiazepines are usually avoided in this population, and if we are using opioids, we'll use a short-acting opioid like fentanyl and titrate it gradually. The key is to start with minimal targeted pre-medication and avoid over-sedation in CLD. There are a few studies which have showed the benefit of pre-medication in the intraoperative period and in the post-operative period. This study showed that this is a non-cirrhotic patient study. This showed that midazolam pre-medication reduces propofol dose requirements for multiple anesthetic endpoints. All the patients received either midazolam 0.05 milligram per kg or a saline placebo, and we found that the requirement of propofol for various responses like hypnosis, motor, and EEG endpoints were significantly reduced in that group which received midazolam pre-medication than the saline control group. Another study to establish the safety and efficacy of oral ketamine pre-medication in children undergoing daycare surgery. Children were divided into 3 groups. Group A for 5 milligram per kg of oral ketamine and 10 milligram. Group B was 10 milligram per kg of oral ketamine and Group C received no ketamine. Adequate sedation and anxiolysis were observed in Group A and B with better parent separation anxiety relieving. So oral ketamine is an acceptable and safe medication for children. In order to establish the safety of pre-medication in CLD patients, we did a study in pediatric population to determine the requirement of intravenous propofol after pre-medication with intranasal ketamine and dexmedetomidine in pediatric patients undergoing upper GI endoscopy. It was also an RCT conducted in our institute, and the data is yet to be published. We took 50 patients and we gave in a group A, we gave intranasal dexmedetomidine 2 microgram per kg with ketamine 4 mg per kg. And in the group B, we gave intranasal distilled water. We found that the intra-procedural requirement of propofol was very much less in group A that received appropriate pre-medication, and separation anxiety was very less, and the children were comfortable throughout the peri-procedural period. So the main points are all these patients come under daycare admissions. So we have limited time to assess the patients, and all age groups from pediatric to geriatric population comes under for daycare procedures. A careful anesthetic assessment is essential to identify the red flags, and assessment of the reason for intervention and any associated comorbids is essential. CLD population per se are high risk, and presence of any underlying comorbids like cardiac or respiratory can exacerbate the situation. Fasting status of the patient should be noted, and it is very, very important that adequate fasting status is maintained and quick airway assessment should be done. Next presentation will be procedure-specific considerations by Dr. Sai Kishore. Thank you.
Good morning, all. So I will talk about the common daycare procedures which happen in ILBS and procedure-specific anesthesia concerns. So this is the scope of NORA in ILBS. So we provide services for hepatology, vascular, CT suits, MRI suits, and PET CT suits. So one of the most common procedure which happens here is the upper gastrointestinal endoscopy. So what are the anesthesia concerns for this? So there is going to be a shared airway between the endoscopist and anesthesiologist. So securing an airway during the procedure is going to be difficult. There is always an aspiration risk because of the full stomach, active bleeding, and obstruction. So strict NPO guidelines wherever possible should be enforced. Airway compromise can happen because of the bleeding, secretion, and clots. Now, because of the sedation, there is always a risk of hypoventilation. EtCO2 is mandatory whenever possible. Rapid desaturation happens especially in patients with OSA, obesity, and elderly. So pre-oxygenating them with HFNC 100% to 40 to 60 liters can be done. Now, because of sedation, there is always a risk of hypotension. So NIBP should be kept every 2 to 3 minutes. There is a risk of vagal bradycardia during the scope insertion and during the band ligation. So atropine should be kept standby. In a patient who is coming with active variceal bleed, there is always a risk of hemorrhagic shock. So in those patients, 2 large IV bore cannulas with blood products should be ready. Now, because of the scope insertion, there can be gagging and retching. Because of the insufflation of the gas, there can be diaphragmatic splinting, decrease in FRC, and respiratory distress. These all should be kept in mind. And during the therapeutic procedures like banding, glue injection, and APC, there can be pain and vagal response. So before these procedures, the sedation should be deepened. In 2024, the British Society of Gastroenterology gave a key consensus point which illustrate that we should do mandatory risk stratification for all population. The anesthesia doses should be tailored according to the individual needs and not a generalized approach. minimum mandatory standards should be kept. Any patient who is receiving sedation should receive supplemental oxygen, and capnography should be recommended for patients who are undergoing deep sedation and high risk patients like OSA and BMI more than 35. Now, coming to special population, breastfeeding can resume once after the patient is awake. And for elderly patients, there should be a significant dose reduction, approximately 50% of the dose. Now, coming to recovery, the patient should be monitored until the patient recovers to the baseline conscious state. And during the discharge instructions, the patient should be prohibited from driving for the first 24 hours and taking any major decision for the 24 hours. Now, coming to one of the rare complications which can happen during the endoscopic procedure, there can be a pulmonary embolization of the cyanoacrylate glue. So there have been various case reports regarding this. So this is how it looks, and this can cause desaturation either in the post-operative period or a sudden hypotension with respiratory distress during the procedure. Now, coming to one of the most common as well as one of the complex procedures for both endoscopists as well as the anesthesiologists, which is the ERCP. This is how ERCP looks like in our institute. Now, as we can see, there is hardly any space for anybody to go near the head end. So securing an airway during the procedure going to be very difficult. And we can see the oxygen port as well as the suction port is going to be kept behind the monitors. So accessing them is also a difficulty. Now we can see the patient is prone or semi-prone during these procedures, which can change the physiology of the patient. So what are the considerations in ERCP? So as I told, the position is going to be either prone or semi-prone. So there is going to be limited airway access, and it is going to change the respiratory and CVS physiology. And there can be position change midway during the procedure. So anytime we are doubtful about the airway, secure the ET tube before turning the patient and reconfirm the tube position before proning. Now, any procedure which is lasting more than 60 minutes has 8 times higher risk of adverse events. So there should be a constant communication with the endoscopist and always reassess the sedation every 15 minutes. There is a risk of desaturation in 22% of this population. Use HFNC whenever possible, or nasal oxygen is mandatory. Continuous SpO2 and EtCO2 monitoring should be there, and airway equipment should be ready at the bedside. Now, most of these patients are going to be ASC grade more than 3. So individualize the hemodynamic goals for this patient and reassess sedation every 15 minutes. There is a rare complication of venous air embolism during the procedure. So always suspect this when there is a sudden CVS collapse, and we should turn the patient immediately to the left lateral position. There is always a risk of contrast-induced AKI for this patient, and it is higher in liver disease because of the possibility of HRS. So check creatinine pre-procedure always, and hydrate the patient 1 ml per kg per hour when the patient is in NPO. Avoid nephrotoxic drugs for these patients. Now, what is the prevalence of anesthetic and gastrointestinal complication for ERCP? So it has been found that 37% of the complications were hemodynamic instability, followed by desaturation, which amounted about to 11%, followed by the GI complication, out of which the pancreatitis was most common, followed by bleeding. Coming to one complex procedure, which is the intragastric balloon. So the anesthesia concerns include obesity-related complications like airway, respiratory, circulatory, and metabolic complications, followed by aspiration risk and post-operative nausea, vomiting, especially after the insertion of the IGB, and followed by airway obstruction, which can happen during the removal of the IGB. So what are the differences between IGB insertion and IGB removal? So the primary goal during the IGB insertion is going to be smooth induction and procedural comfort for the patient, while in IGB removal, it is going to be airway protection and debris management. The procedure time is going to be very predictable in IGB insertion, while it is variable and difficult in IGB removal. The aspiration risk is moderate in IGB insertion because of the standard obesity-related risks, while in removal, it is because of the retained solids and liquid debris. So it is always recommended to secure the airway in IGB removal with RSA with an ET tube in situ. So the most common post-op issue is going to be nausea and vomiting in IGB insertion, and it is going to be trauma as well as aspiration pneumonitis in IGB removal. So there have been articles which denote that even after standard NPO guidelines and prolonged NPO guidelines up to 12 hours, there's going to be residual food amount present in the IGB patients. So it should be taken into consideration. So what are the challenges in patients who are obese? First is going to be the respiratory challenges. The patients have rapid desaturation because of the reduced FRC and because of the history of OSA and OHS. And cardiovascular, these patients have increased cardiac workload with a history of hypertension. These patients should not be dosed according to the total body weight. They should be dosed according to the ideal body weight. And there is going to be positioning difficulty for these patients. For these patients, minimum ASA standard monitoring should be taken care of. And capnography is mandatory for these patients because it is the earliest sign of airway obstruction or hyperventilation. NIBP cuff should be appropriately sized for these patients. Now, specific investigations for this patient include airway assessment, OSA screening, and in a patient who we are suspecting to have pulmonary hypertension, a baseline ECG, echo, chest X-ray, and an ABG should be mandatory. Now, coming to airway management, difficult airway card should be always available for this patient, which includes a video laryngoscope and a second generation supraglottic airway. Now, ventilation support in the form of CPAP and high flow nasal cannula should be available. So in case the high flow cannula is not available, there is a modification for it where we use the nasopharyngeal airway with an ET tube connector connected to a Mapleson circuit. Now, what is the advantage of it? Because the Mapleson C circuit has the reservoir, it can give 100% oxygen for the patient and allow some positive airway pressure in the patient who are having some spontaneous efforts. So this is how it looks like inside the patient. This is going to be the nasopharyngeal airway, which is connected to the Mapleson C circuit with the reservoir bag. Coming to endoscopic sleeve gastroplasty, this is one such procedure which should be undertaken under GA with airway secured using endotracheal tube. Why? Because these patients have the risk of capnothorax, tension pneumothorax, and capnoperitoneum because of the CO2 escapes during the suturing. And there is going to be an increased aspiration risk because of the prolonged procedure as well as the decreased gastric volume post-procedure. Now, deep neuromuscular blockage is required when the suture is being taken to prevent gastric perforation. These procedures can either range from 90 to 20 minutes. So temperature monitoring and pressure monitoring are necessary. These patients have higher incidence of post-operative nausea and vomiting. So multimodal antiemetic should be mandatory for these patients. So what are the anesthesia concerns for colonoscopy? There is going to be a higher risk of dehydration and electrolyte imbalance because of the prep fluid. And there is going to be a risk of increased aspiration because of the residual prep fluid which is in the stomach. Now, vagal stimulation can be present because of this sudden advancement of the scope or because of the manipulation of the scope through the splenic flexures. Respiratory impact because of the insufflation of the stomach, there is going to be diaphragmatic splinting and reduced FRC. Airway management, these patients are going to be in left lateral position. So assessing the airway is going to be difficult. Now, in colonoscopy, there is the most common complications are going to be hypotension, desaturation, and airway obstruction. It has been found that 5 pre-existing factors are independent. They are going to be independent risk factors for colonoscopy. They are pre-existing cardiovascular risk, pre-existing respiratory disease, functional capacity meds less than 4, nutritional screening score more than 1, and single dose bowel prep. Now, these are going to be the higher patients population who are going to be at the higher risk during colonoscopy sedation, either elderly, frail, patients with pulmonary diseases, patients who are obese with the history of OSA, and patients who are having cardiovascular diseases. Coming to HVPG and TJLB, see, the anesthesia concerns include these patients can be coagulopathic, so there is a risk of bleeding and hematoma. There is a risk of arrhythmia either during the guide wire insertion or during the procedure. There can be inadequate NPO status for these patients. Coming to bronchoscopic procedures, as with endoscopy, this is also going to be a shared airway with the proceduralist, and there can be a risk of airway obstruction during the procedure because of the tumor or the compression. There can be circuit leak, especially while the procedure is undertaken under rigid bronchoscope, and there is a risk of hypoxia because of apnea, suction, and bleeding. Respiratory complications include laryngospasm, bronchospasm, persistent cough, and airway edema. Now, for all these procedures, it is better that the complex bronchoscopy procedures are always undertaken under general anesthesia with the airway secured either using supraglottic airway, endotracheal tube, or in case of if the rigid bronchoscopy is used, we have to make sure that the patient is getting ventilated because it is a high leak system. Now, inhalation anesthetics cannot be used for this procedure. We have to use Tiva and muscle relaxation during this procedure, and 100% oxygen should be kept for these procedures. Now, endobronchial ultrasound is one such advanced procedure which is undertaken for lung cancer staging, mediastinal lymphadenopathy diagnosis, central lung mass diagnosis, and mediastinal mass evaluation. It is better to do these procedures under general anesthesia after securing the airway or using a high flow nasal cannula to provide 100% oxygen. Coming to vascular daycare procedures, the most common and the most complex procedure here is going to be TIPS, because these patients can be full stomach either because of the delayed gastric emptying or because of the massive ascites which is going to be present for these patients. There's always a risk of active hematemesis for these patients, so any airway securement should be done before the procedure starts. There can be hemodynamic instability. That is because after the stent is opened, there is going to be a preload surge into the right ventricle, which can cause right ventricular failure. So, and preoperative echo is mandatory. Coagulopathy and bleeding is going to be present for these patients. So, there is a risk of liver capsule rupture during the procedure or an accidental artery puncture during the procedure. Post-operatively, these patients can go into hepatic encephalopathy. So, the drug dosing should be noted for that. Now, this is going to be an ideal setup for the TIPS. As we can see near the head end, the radiologist is going to be there. So the anesthesiologist doesn't have the head end for securing the airway. So any securement of airway should be done before the procedure. Now, comparison of general anesthesia versus which is local anesthesia in elective TIPS, it has been found that the patients who are undergoing TIPS under general anesthesia with the airway secured had shorter post-operative stay, had a radiation dose which is significantly lower, had fluoroscopy time which is significantly lower, had contrast volume which is significantly lower. So it has been found that general anesthesia may facilitate more stable procedure conditions for these TIPS procedure. Coming to percutaneous transhepatic biliary drainage, the anesthesia concerns are going to be pain during the needle insertion and during the balloon dilation, bleeding for these patients. These patients can be critically ill because of the pre-existing cholangitis, and these patients can be in inadequate NPO status. Now, in patients who are having a risk for general anesthesia because of the deranged LFT, it has been found that ultrasound guided oblique subcostal tab block is an effective technique to provide anesthesia. Coming to microwave and radiofrequency ablation, so this is the indications are HCC, liver metastasis, recurrence, and for pain control in case of palliative care. It has been found that deep sedation for radiofrequency ablation plays a crucial role not only for the patient as well as the operator comfort, but also for the long-term oncological outcomes. Coming to MRI, CT suit, and PET CT suit. So these are infrequent locations even among NORA. So always follow the core principles of NORA and preparation of suit. Arrange compatible monitors, instruments, airway adjuvants, and oxygenation. Specifically for MRI, there should be a multidisciplinary team approach to take decision whether the MRI is needed for an ICU patient. Always use only the MRI conditional equipment and avoid long line extension because there is always a risk of disconnection. For patients who are having pacemakers or ICD, cardiology opinion should be taken and MR conditional programming should be done for that. In case of a cardiac arrest inside the MRI, the scan should be immediately stopped and the resuscitation should be done outside the MRI, which is a pre-designated resuscitation area. During an emergency field shutdown, which is called the quenching, there is a risk of hypoxia because of the helium release. So it should be taken care and the patient should be removed as soon as possible. So the best practice is to use proper audits of protocols and incidents. Now, this is an MRI console in ILBS. So there is hardly any visibility of the MRI scanner as well as the patient as well as the monitor. The only monitor which we can see here is going to be your respiratory rate. So we have to make sure that the patient is comfortable inside, and multiple monitors should be included for this. Now, coming to PET CT, we have found that the PET CT console is very far away from the patient's head end. So to monitor the airway, to monitor the ventilator as well as the monitor, we have found that using a Google Meet for this is an innovative idea, and we can use this in resource limited settings. So coming to pediatric population, so major physiological concern in these populations are including airway collapse, laryngospasm, rapid desaturation, high apnea risk, and limited physiological reserve. So when we are assessing the patient, a medical history for nutrition, GERD, and medication should be done. If the patient is taking steroids, a stress dose evaluation should be done. These patients are going to have difficult IV access, so it should be checked before the patient is taken up for sedation. So, what are the indications for intubations? Infants less than 1 year or less than 10 kilos, OSA or difficult airway, high aspiration risk, and complex procedures are strong indicators for intubation. Now, some of the procedure specific consideration for colonoscopy, it is always preferred that the patient has spontaneous breathing, because after giving muscle relaxation, the abdominal tone is lost and the bowels fall. And while using manometry, we should avoid opioids except for remifentanil. After peg placement, the tube should be properly secured before moving the patient. And a close coordination with an endoscopist is mandatory in pediatric patients. The ASA standard monitor should be used for the pediatric patients, and capnography is going to be essential and mandatory in these patients. Since these patients have very low FRC and high risk of desaturation, we can use either high flow nasal cannula for the pediatric GI endoscopy. So it has been found that while using nasal cannula of 4 liters per minute and high flow nasal cannula of 60% FiO2, 2 liters per kg per minute, when we have compared this, the lowest SpO2 which was occurring during the nasal cannula, it went up to 68%, while in case of high flow nasal cannula, it went only till 88%. And the duration of hypoxia was also significantly shorter in the patients who are undergoing sedation under high flow nasal cannula. And the secondary findings included the better hemodynamic stability, better respiratory rate, and better recovery and safety in patients undergoing sedation under high flow nasal cannula. So this is how a high flow nasal cannula looks like. Now, as we have seen, there are different kinds of patients undergoing sedation under different kinds of anesthesia. So the next presentation is going to be by my colleague, Dr. Hina.
While you are going, I must say you have done a good presentation. You have taken up the practical problems. But my request to anesthesia colleague and the students is not to use these kind of machine learning slide making. Try and make your own slides, which is much better. Yeah. Thank you. And Gaurav, very good. That innovative thing is Gaurav around. Yeah, very good. I'll have to leave, so I just have to make a request that day after 18th, we have World Liver Day celebration. Starting at 10 o'clock, the Lieutenant Governor and our Chairman, Chief Secretary, all are coming. So please ensure that you are here 5 to 10 students and their teachers, and inform everyone else. And thank you for good presentations. Okay.
I'll be continuing with monitoring types of anesthesia and airway management. So monitoring is a vigilant assessment of patient's physiological state, oxygenation, ventilation, and circulation during surgery procedure to ensure safety and stability. Though US found a new technique of giving anesthesia by the certified nurse, propofol sedation, and this article showed that our gastrointestinal endoscopic procedures performed by anesthesiologist safer than the sedation given by endoscopist. A large study of 476,000 endoscopic procedures, they found anesthesia given by anesthesiologists reduced the complications, minor complications to 1.1% and serious complications to 0.34%. Minor complications accounting for nausea, vomiting, pain, and major complications as low as cardiac arrest, aspiration, pneumonia, neurologic complications, drug reactions, injury, and death can be reduced if the sedation is given by the anesthesiologist. So, though it was found to be cost effective if done by the nurse, but the adverse effects were as close as 30.9% if given by the nurse, and it should be always done under anesthesia concern. Anesthesia and complications accounted for cardiovascular and respiratory events. So they concluded that there was a critical gap in understanding the safety of propofol when given by a trained nurse, especially in outsetting patients. So standard monitoring for all patients include oxygen saturation, NIBP, and heart rate monitoring. And for selected patients having cardiorespiratory or pulmonary complications should include end-tidal CO2, sedation depth monitoring using BIS, temperature monitoring, and invasive BP. So this is followed by all American, British, and European countries that basic monitoring should be include NIBP, pulse oximetry, and electrocardiography, while selected patients should include capnography and BIS monitoring. So BIS monitoring is actually important for monitoring in daycare procedures so that we can reduce the concentration of drugs, especially in reverse cirrhotic patients, when we know that the drug requirement will be less in these patients. So end-tidal CO2 is now the standard of care for monitoring. So, and it is especially important in procedures like ERCP, where sedation should be given in the form of general anesthesia, but here, as we are giving it only under sedation, and ETCO2 monitoring is difficult, as we can see in this graph. So we had an innovative approach where a three-way was connected to the suction catheter, which was introduced through the nasal airway, and ETCO2 was connected to the three-way with the oxygen port. So, and the suction catheter was kept near the vocal cords, and we could get a proper ETCO2 curve and ETCO2 monitoring of the patient. Now, what are the types of anesthesia? It ranges from monitored anesthesia care, intravenous sedation, anesthesia without intubation, and with intubation. So monitored anesthesia care is a specialized care provided which is done for the diagnostic and therapeutic procedures, which includes topical anesthesia, local anesthesia, and analgesia. So topical anesthesia ranges from lignocaine spray 10%, 2 puffs given on each side of the laryngeal wall and 2 puffs on the posterior pharyngeal wall. Lignocaine viscous solution 2% can also be given 5 ml 5 minutes before the procedure, or lignocaine gel can be applied with a swab stick over the peritonsillar areas and the palate. So advantages being patient can communicate, there is a short recovery time, cost effectiveness. Disadvantages, patient satisfaction, endoscopic comfort, and it is not possible for children and non-cooperative patients. So previous studies showed that lignocaine spray was found to be better, but now the recent studies of 2026 shows that lignocaine jelly applied over the palate and the peritonsil area was found to be safe, suitable, and effective option to prevent the gag reflex and to undergo the endoscopic procedures. Another technique is intravenous sedation, which is a safe, fast-acting, effective technique where the medication is introduced directly into the vein, and it is with profound comfort with partial or total memory loss. So it is given by according to the depth of anesthesia which is needed, which ranges from minimal sedation, moderate sedation, deep sedation, and general anesthesia. So it depends upon the responsiveness, airway, spontaneous ventilation, and cardiovascular function. So for endoscopic procedures, we usually require moderate to deep sedation, where the patient can have purposive movement with the painful stimuli. Airway intervention may or may not be required. Spontaneous ventilation may be inadequate, and cardiovascular function is usually maintained. So we usually go by moderate to deep sedation, where drugs like propofol, ketamine, opioids, etomidate for the cardiovascular unstable patients, and the newer drugs like alpha-2 agonists, that is dexmedetomidine, are used. It has advantage of patient and doctor's comfort, short recovery time, doses can be titrated, but the disadvantage of nausea, dizziness, post-procedure monitoring is needed, and there is a risk of aspiration. Most commonly used drugs are propofol, ketamine, etomidate, dexmedetomidine. Midazolam is usually avoided, and fentanyl, it can be used in small doses. Propofol is the drug of choice as it has both hepatic and extrahepatic excretion. Dose requirement is less, it has rapid onset, but the disadvantage of hypotension, respiratory depression is also present. Midazolam is usually avoided as it has the risk of hepatic encephalopathy, also it has hepatic metabolism. Well, fentanyl can be used in small boluses. Infusion is avoided as it gets accumulated with repeated doses. Propofol sedation has found to be having less complications, that is 39% less complications in the studies, as it has rapid onset of action and strong antiemetic and antipruritic effect with rapid metabolism for short procedures. We have got another new magical drug, that is dexmedetomidine, which has a procedure which can have a conscious sedation, where the patient is conscious but patient will not feel any other thing. But there is a risk of bradycardia hypotension, so it should be used with proper dose in CLD patients. Another drugs like ketamine should be used in asthmatic patients, where we want to preserve the airway reflexes and support the BP in hemodynamically unstable patients. Etomidate is usually used in patients with cardiovascular instability, and it is and we have found that when etomidate was compared with propofol for MAC procedures under ERCP at ILBS, a randomized control trial was done, and we found that it offered better hemodynamic and respiratory stability than propofol. Another study done to see the target concentration of propofol for sedation in patients in ERCP, which was done using a TCI pump. This pump has the ability to maintain the plasma concentration of a drug in a patient when the other parameters like weight and height of the patient is introduced in the infusion pump. So this study showed that a mean concentration of propofol was reduced in CLD patients up to 2.2 microgram per ml for ASA1 and 2 patients. This is an ongoing study of the effect of dexmedetomidine on the target plasma concentration of propofol using BIS monitoring for ERCP procedures. So here also the propofol is given using a TCI pump and dexmedetomidine is added so that we can reduce the dose of propofol and the side effects using BIS monitoring, which will help in depth of anesthesia. So now whether ERCP should be done under sedation or GA. So it should be done under, it is usually done under sedation at ILBS. And it is effective in COPD or asthma patients where you want to avoid intubation to prevent bronchospasm. But when it is done, when the procedure is short with low complexity and for the diagnostic and simple therapeutic procedures. But GA is needed when the patient is full stomach, has a gastric outlet obstruction, high aspiration risk, and for the prolonged and high complex procedures. Then comes general anesthesia where there is loss of consciousness with IV and inhalational agent with or without muscle relaxation. So it can be done without intubation, where the procedure is done with mask ventilation, usually in pediatric patients, with intubation or with supraglottic airway devices, that is laryngeal mask airways. So general anesthesia is usually needed in pediatric, non-cooperative patients, patients with cardiovascular, respiratory instability, full stomach, risk of regurgitation, hemodynamic instability, and active upper GI bleed. Elective intubation is better. As an emergency scenario, it is difficult with oral endoscope in C2 and lateral positioning of the patient if the patient desaturates. General anesthesia is usually done for endoscopic ultrasound in ERCP, but at ILBS, we are doing it under sedation. But now as the conditions like morbid obesity, achalasia, and superficial cancerous, non-cancerous mucosal lesions are treated using endoscopy, like procedures of endoscopic submucosal dissection, endoscopic sleeve gastroplasty, or peroral endoscopic myomectomy, general anesthesia with endotracheal intubation is needed, as it can land up in complications like hypoxemia, pulmonary aspiration, venous air embolism, pneumomediastinum, pneumothorax, emphysema, life-threatening bleeding, and perforation. General anesthesia has the advantage of airway control safety, safe for high-risk and critically ill patients. Patient will be immobile and control over the physiological parameters is there. But it has the complications of intubation, post-procedure monitoring is needed, and it has a longer recovery time. Another thing which has come up is supraglottic airway device, usually called as laryngeal mask airway. It is used in interventional radiology procedures, MRI suits, endoscopy units, and it has advantages of ease of insertion, reduced airway morbidity, and hemodynamic stability. The newer LMA which we have got is a gastro LMA, which has the ability where the oral gastroscope can be introduced through the through the LMA, where both the airway is secured. Also, the procedure can be done using the gastroscope. But this has the disadvantage of that there is a movement restriction with the gastroscope. It is difficult. It is getting difficult for ERCP procedures. And also, if a banding is required, that is EVL, the gastroscope cannot enter through this diameter. The gastroscope procedures, LMA gastro has been used widely for the endoscopic procedures overall. And there are many studies showing that when it was compared with other laryngeal mask airway or endotracheal intubation, it was found to be effective and it is helpful for daycare procedures. Now, airway management is important because anytime when the patient desaturates, we should have a rescue procedure. So initially we start with a head tilt, chin lift, and jaw thrust maneuver whenever the patient desaturates. Further, if the patient continues to desaturate, we go for mask ventilation with two-hand technique. And if it further desaturates, we'll end up with endotracheal intubation or laryngeal mask airway. So after endotracheal intubation, we have found that when the patient comes with reduced mouth opening or one finger mouth opening, we're giving sedation to see such patients at a place where we don't have access to video laryngoscopes or flexible fiber optic devices. Sedating these patients is difficult, as if they desaturate, it is difficult to intubate such patients. So we came up with some rescue procedures which are reported in anesthesiology journals also, that when such patient was sedated with a nasal gastroscope, and the ET tube was already mounted on the nasal gastroscope, and the scopy was done, so that if the patient desaturates, the scope can be taken up to the vocal cords and patient can be intubated using the same gastroscope. Another technique we used, that we did bougie guided intubation in these patients with the oral gastroscope, that when the scope is introduced in the patients with a reduced mouth opening and there is a need of intubation, the gastroscope is placed near the vocal cords. This blue colored bougie is introduced through the bite block, and as we can see, the bougie is inserted through the vocal cords and the tube is loaded over the bougie, and we can see the bougie can be inserted inside the trachea under vision using the oral gastroscope. So this way we can secure the patient's airway in difficult situations. This technique was further simplified, where guide wire was used to intubate a patient. So here, when the endoscopy is being done, the guide wire is inserted when the scope is placed near the vocal cords, and the guide wire can be seen inserting to the vocal cords, and then the gastroscope is removed outside. Guide wire in situ. The ET tube is mounted over the guide wire. Again, the gastroscope is introduced to look for the ET tube, and the ET tube can be used for intubating the patient. ET tube is introduced into the trachea and the patient is intubated using the guide wire. So these techniques were innovated here in ILBS and are published in anesthesia journals. Another thing which has come up, which is high flow nasal oxygenation using a high flow nasal cannula. This has been used since 2018. It is a non-invasive respiratory support system which can deliver heated, humidified air up to 60 liters per minute flow and 100% FiO2. So this is mostly helpful in obese and high-risk patients and is used in endoscopic, bronchoscopic, and transesophageal echocardiography procedures. And it is mostly useful in obese patients. So it has got multiple publications and it is very much helpful, and it has advantage over nasal cannula that it provides humidified air, preventing the nasal irritation. So multiple studies have come up and it is very much helpful, but the only disadvantage with this procedure is it requires a high volume of oxygen, that it requires around 60 liters of oxygen per minute. So we did a study at ILBS where we compared 3 flow rates, and we could found that 30 liters of oxygen can also be used to sedate such patients, and the complication rates were comparable with all 3 concentrations of oxygen used. So we could save a large amount, that is around 1200 liters per hour of oxygen. Coming to the end, post-procedure sedation, post-procedure recovery. So we should know when to transfer the patients from the endoscopy suite to the recovery and from recovery to home or to ward. So a modified Eldred score can be used to send the patient from the endoscopy room to the recovery, which includes activity, respiration, circulation, consciousness, and oxygen saturation. If the score is more than or equal to 9, patient is safe to be discharged to the PACU unit. Another score is Ramsay sedation score, where the sedation of the patient can be seen. It is a simple score where the patient is seen whether is awake, cooperative, response to command, or is asleep with a brisk response, sluggish response, or no response to stimulus. And the last one is post-anesthesia discharge scoring system, which is used to discharge the patient from the endoscopic suite to the ward or to home, which includes the vital signs, activity, nausea, vomiting, pain, and surgical bleeding. Also, a study was done in colonoscopy patients, which found that using this score, patient could be discharged early than the control group to the wards. At the end, I would like to say this approach should be followed, that is sedate CLD, start low, go slow. There's always a risk of encephalopathy in CLD patients. Drug of choice will always be propofol. Airway and capnography is important for monitoring. We should titrate the doses using BIS if available, and there is an extended recovery monitoring. Thank you.
Yeah. Thank you very much. Thank you, Reverend, for a very well structured presentation for the